Hi guys, this is take 3 for final review. I hope you're having a great day. Tomorrow's another day. I want you to remember the term kyphosis. Look it up. Sometimes, as you guys are planning your exercises for your patients' home exercise program for final competencies, I want you to remember sometimes you could get some compensations. The first course of action is to make certain that whatever it is you're giving your patient isn't too weighted, the resistance isn't too strong, overpowering or over-resisting, because we want to achieve that goal as patients. So we're going to do whatever it takes to achieve that goal, and that's where those compensations could come from. So don't try to decrease the resistance if you notice that. Be able to grade your exercise programs up or down, whichever way they need to go for appropriateness. Signs of a DVT, we've gone over this, but it's going to be on that warmth, that pain in the calf area. Patients are more at risk post-op surgeries, and you can do a Homan sign, which is where we're actually dorsiflexing the foot, and pain is a positive indicator, a positive Homan sign, which would actually need to stop everything, and the patient needed to be referred, go talk to the PT or contact their PCP, but they need to be further evaluated by somebody else, and it's an immediate red flag, especially if you have the presence of the warmth and pain there in the calf as well. Your Salva maneuver, we've talked about this guy. Know that one of the biggest reasons a lot of our UPS workers actually die of Valsalva is they stop, they pick up those heavy packages, they hold their breath, and then that causes that intrathoracic pressure to increase their blood pressure. So know that that's actually what's happening in there when that happens. This, again, you're going to hear this here and now when it comes to pneumatic compression. Pneumatic, P-N-E-U-M-A-T-I-C, pneumatic compression. Whenever that is done, it's a mechanical compression force, and we're looking to never set the parameters higher than the patient's diastolic blood pressure readings. Aren't you glad you listened? Pneumatic compression, never set higher than the diastolic blood pressure readings. The diastolic reading. Never, ever, ever. All right, this has actually gone back and forth between PT2 and PT3, but where you guys are going out on clinicals really soon, again, this is heard here and now. I want you to know a little bit about personal protective equipment, and when it comes to donning and doffing them in the correct sequence. So how to put on your personal protective equipment in the correct sequence. You need to know that first. Gown, mask, goggles, gloves. Okay, easy. Gown, mask, goggles, gloves. All right, so we've got an individual that's been doing a lot of research. We've got a lot of you guys that have been doing a lot of research. So you've collected 10, 20 different research articles for this evidence-based project that's coming up. One of the reasons that you're collecting that quantity of articles is not to actually, confirm reliability of the findings or to formulate a research problem or to determine a hypothesis, but that collection of that large lump sum of evidence-based peer-reviewed articles is actually more so for a literary review of current findings. Know why we use the rate of perceived exertion scale. Know how to increase strength versus endurance when it comes to a home exercise program for patients. When we discussed the chin tucks, the double chin, we're getting some suboccipital flexion there, and that's where I'm really educating my patients that come with this forward head, kind of this student study forward head posture, forward. If we bring them into that chin tuck, we actually get some suboccipital flexion for that forward head posture. Know your abnormal and your normal end feels. Always, no matter what, the best indicator of a patient's return to prior level of function, or the best indicator of a patient's future expected outcomes, is based on their prior level of function, regardless. If we have a elbow, a knee, an ankle that's swollen, great things that you can use with that are elastic wraps, compression wraps, massage. A cool whirlpool would be one of the least beneficial things that you could use during that. When it comes to stretching, stabilizing different body parts is really, really important, as is the duration of the stretch and making certain that the alignment is accurate. Alignment makes a huge importance. So know what's really, really important when it comes to stretching. Know what your TFL and your iliotibial band does. That way you can know how to put them in the best stretched position. Just want to go over this one because there can be some controversy on it. So neutral pelvis here. If a patient has short hip flexors and tight erector spinae, so the tight erector spinae aren't actually going to balance this out. So you've got your tight hip flexors that are pulling this pelvis into an anterior pelvic tilt, and your tight erector spinae are elongating that or increasing that. So short hip flexors combined with the tight erector spinae is really going to put you into an anterior pelvic tilt. Again, know your plumb lines with a lateral view, posterior views. I want you to be able to critically think. If a patient is not, if a patient is able to do more than 8 to 12 reps, are we strengthening that patient? Is that the optimal therapeutic exercise to obtain strengthening for that patient? If a patient begins to perspire, should we be stopping exercises? If a patient's respiratory rate is increasing, are we getting an optimal level of therapeutic exercise? Critically think those guys through. Know your contraindications for lumbar traction. A recent spinal fracture or a surgery that required stabilization would be contraindicated. An old compression fracture that's healed would not be contraindicated, as long as it didn't require surgery and stabilization in the surgery. All right, so if we have an ORIF, open reduction internal fixation for the patella, movement is actually contraindicated. However, if we have a patient with a total knee, movement is indicated. Movement is also indicated to heal ligaments and to increase or maintain range of motion. Some things that we can use for movement is a CPM, but you wouldn't want to utilize that on something where movement was contraindicated, which would be for an ORIF for a patella fixation, open reduction internal fixation for a patella. You learned that here, right now. Aren't you glad you listened? Always instruct a patient to exhale on exertion. Know what your infraspinatus and your teres minor do. That way you can know how to stretch them and you can know how to strengthen them. Know what a closed chain exercise is versus an open chain exercise versus an isokinetic exercise. Lateral epicondylitis. It's your tennis elbow. We're going to want to stretch the wrist extensors. We're going to want to do this with full wrist flexion, pronation, and elbow extension. Lateral epicondylitis, to stretch our wrist extensors, we want full wrist flexion, pronation, and elbow extension. GTO. GTO monitors the tension in each muscle segment. Remember that. Know what a scoliosis is. Know the best way to visualize scoliosis when it comes to that postural assessment. How are we going to have that patient positioned? So a circumduction gait tends to involve oftentimes some hip hiking and swinging the leg outward. I bet Matt could probably, there's some chairs over here. So we're coming up and out. And we're circumducting that gait. Quite often that's because of a leg length discrepancy more than anything else. Peripheral joint mobilization should be covered in a kines a little bit, and I just want to send home the message that peripheral joint mobilizations are great for improving joint capsule, range of motion, flexibility, and ligamentous tissues. Okay, that's number 3.